All right, let's get started. My name is Victoria, and on behalf of the Education Work Group, we would like to thank you all for attending our August Lunch and Learn presentation on reducing cancer disparities in Black and Hispanic communities. A few housekeeping items before I introduce today's speaker. First, we'll be recording today's presentation, which will be made available on the intranet over the next few days. Second, everyone present here today will receive a certificate for their attendance. Today's presentation is eligible for 1 continuing education credit, which will be listed on your certificate. Third, we will have a short survey after we end for the day. Please take a few moments to fill that out. We would greatly appreciate your feedback on today's presentation. And lastly, we do appreciate and strongly encourage your questions. However, please hold your questions until the end of the presentation. And now I have the privilege of introducing today's speaker. Dr. Adam Green is an associate professor of pediatrics and investigator in the Morgan Adams Foundation Pediatric Brain Tumor Research Program at the University of Colorado. He did his undergraduate work at Dartmouth College and earned his MD from NYU School of Medicine. He then served as a pediatric resident and chief resident at Children's Hospital Colorado, followed by a fellowship at Dana-Farber Boston Children's Cancer and Blood Disorder Center, where he worked with Mark Curran and trained in the labs of Andrew Kung in Stewart, Oregon. He then returned to the University of Colorado in 2014, where he has been mentored as a junior faculty member by Rajiv Vibhakar, as well as Nick Foreman. He is an attending physician on the neuro-oncology and oncology services in the Center for Cancer and Blood Disorders at Children's Hospital, Colorado. Dr. Green is also a member of the CNS Tumor Committee of the Children's Oncology Group. Dr. Green has been awarded the ASVO Young Investigator Award, the St. Baldrick's Foundation Fellowship and Scholar Award, the Hyundai Hope on Wheels Young Investigator Award, and K-12 and K-08 awards through NIH. Thank you, Dr. Green, for being here with us today. I'll stop sharing my slides so that you can pull yours up, and then we will be ready to begin whenever you are.
Great, thanks so much, Victoria. Thanks for that introduction. Yeah, thanks you to everyone for joining today. Really appreciate it, and yeah, it's great to be here to be able to present to you. Let me just share here. All right, those showing up okay?
Yep, looks good.
Perfect. Okay, yeah, so my talk today is on disparities in cancer based on race ethnicity, and we'll also touch on socioeconomic factors as well in cancer disparities across adult and pediatrics. I'm a pediatric oncologist, and so you know, I'll start with kind of knowledge of, I can go to the objectives here, but okay. Yeah, so we'll start with kind of what is currently known about adult and pediatric cancer disparities. And then I'll talk about progression of my work on establishing existence of disparities in some pediatric cancer subtypes through investigating the causes of those disparities, and then in piloting interventions to address disparities. I'll talk a little bit about current work on interventions that we're conducting, as well as others in the field, and what we can learn from those. And then I'll talk about some future directions of work that needs to happen to make cancer care equitable across all patients. Okay, so there are differences. So when we talk about cancer disparities, we're talking about differences in morbidity and mortality from cancer based on demographics, so racial and ethnic, and then socioeconomic factors. And there are multifactorial causes to disparities. And so those lie in the healthcare system. So, we know that there are a lot more Black and Hispanic and patients of minority race ethnicity who are uninsured in the U.S. Than white non-Hispanic patients. So insurance certainly plays a role in cancer morbidity and mortality. Socioeconomic status, is correlated with race and ethnicity. And so when we talk about socioeconomic status, that affects the quality of care patients are receiving, the screening they get, and the treatment they receive. And then there are certainly differences in environmental exposures and things like infections across racial and ethnic groups. So, we know that patients of minority race and ethnicity tend to live in areas where there are greater exposure to pollutants. And then when infections impact cancer, things like liver cancer and cervical cancer, those infections have differing prevalence across populations. And we know that when we control for socioeconomic factors, when we look at racial and ethnic disparities, a lot of the disparities are mitigated, but not all, which raises the possibility of systemic bias playing a role, as well as biological factors that may be based on race and ethnicity as well in cancer. Okay, so I thought I'd talk a little bit about kind of what is known about disparities across kind of the most common cancer types. And those are all, in adults, since we know the cancer is much more common in adults than children. So in lung cancer, we know that patients from minority racial, ethnic, and populations, and then patients who are from rural locations tend to bear the majority of the mortality from lung cancer. And there are a couple, kind of pretty well-established reasons for this. One is that these groups are referred less often to smoking cessation programs, since about 80 to 90% of lung cancer patients are smokers. And then again, these patients tend to have higher exposure to air pollution, which is another risk factor. So this is a model that came from a review of lung cancer disparities, basically just looking at the kind of the multi-levels of factors that impact outcomes in these patients. So they come from the environmental factors, the healthcare system, in terms of implicit bias and structural racism, limited number of minority subspecialists, which we'll talk about in terms of representation in the medical fields, but then down to interpersonal and individual factors as well, in terms of health behaviors, language barriers, and then biological factors as well. Breast cancer is the most common cancer type in women, and one of the most common cancer subtypes overall. And we know that multiple risk factors lead to disparities in breast cancer, and we can see especially racial disparities over here. So even though Black and white patients have kind of similar incidence rates of cancer, this is out of 100,000 people per year, the death rates are not equal. And so Black patients have about a 50% increased mortality compared to white patients. And so there are multiple reasons for this. We know that BRCA1, which is a germline risk factor for breast cancer, rates are higher among Hispanic compared to non-Hispanic women. Differences in rates of physical activity and obesity impact breast cancer risk, and those are different based on race and ethnicity. And this is important both decreased physical activity and obesity are risk factors both for incidence of breast cancer and for mortality once patients are diagnosed. There are also differences in tumor biology and treatment response. For instance, Black patients tend to have higher rates of stroke and pulmonary embolus when they receive tamoxifen. So this increases mortality rates. And then they also have increased rates of triple negative breast cancer, both in African-American and Hispanic women. And then there's a history, as we know, of medical abuse and experimentation, especially in Black populations. And this leads to mistrust in many women and treatment differences, especially in surgery. So we know surgery is an important part of breast cancer care, but the surgical rates among Black women are lower than among white women. In colon cancer, so this is one that we, like breast cancer, we have good screening for, but the disparities in colon cancer incidence really seem to emerge, as we see from this chart, kind of in the 80s and 90s when screening for colon cancer became more widely available. And we know that screening rates are much lower among Black patients than white patients. And this really suggests the reason for that, screening, so, when we do colonoscopies, we're mostly looking for precancerous lesions. So, kind of adenomas and polyps that have the chance of becoming cancerous. So by the time that colon cancer is, diagnosed, those are obviously, disease that's further along at that point. And so we've seen the incidence of colon cancer is much higher now in Black versus white populations since screening became more widely available. And then mortality is highest among Black patients compared to white, Asian, and American Indian populations. And then finally, out of the 4 most common cancer subtypes in prostate cancer, one issue that we'll talk about some more is the involvement of minority, racial, and ethnic populations in research studies. And so when this, studies were done in terms of screening for prostate cancer and looking at PSA, so lab tests, and the implications it has for prostate cancer risk, Black men were disproportionately less involved in those studies than white men, and that has implications for kind of how we apply screening and the meaning of those test results for Black men. We just don't have as good an understanding, and that has led to Black men having increased incidence of aggressive metastatic disease when they present versus kind of less aggressive indolent disease in white populations. And so really we see some of the largest disparities, a 70%, 75% increase in incidence and a 2 to 3 times mortality risk in Black patients versus white patients. And so again, we see this kind of model that came from a prostate cancer disparities review of kind of how there are multiple levels that impact these disparities, from, again, structural health system levels to social determinants of health, individual health, and then survivorship as well. Okay, so moving then on to pediatric cancer, this chart is a little busy, but this is from a review that my group published last year, looking kind of across what is known about ethnic, racial, and socioeconomic disparities across childhood cancer subtypes. So again, the common childhood cancer subtypes are much different than in adults. So the most common cancers in kids are leukemias, so hematologic malignancies, and so those have been the best studied in terms of investigation of disparities. And so we see racial and ethnic and socioeconomic disparities across leukemia subtypes. And then brain tumors are the second most common cancers in kids, and we see disparities in central nervous system tumors as well that we'll talk some more about in terms of our work. In solid tumors, these have been somewhat less studied, and the findings have been somewhat more variable. But most commonly, we still do see poorer outcomes and more progressed disease at diagnosis in Hispanic and Black kids compared to their white non-Hispanic counterparts, and in patients with socioeconomic risk factors compared to others. This is especially true in solid tumors in the adolescent and young adult populations, where patients seem to be especially vulnerable. They're tend to be coming off of their parents' insurance at that point, living on their own, kind of probably not taking as good care of their health as they did when they were younger or older adults. And so we see adolescent and young adults, especially in racial and ethnic minority groups and socioeconomically disadvantaged groups, who tend to have poorer outcomes in cancer. So I'll talk a little bit now about the work that we've done in specific pediatric cancer subtypes. So the first project I undertook in this area was looking at a clinical trial cohort of retinoblastoma patients. So retinoblastoma, for those who don't know, is the most common eye cancer, and it's a very common cancer in infants. And so this clinical trial cohort were all patients who had progressive or high aggressive enough retinal tumors when they were diagnosed that they needed to have that eye taken out to cure their cancer. And so this offered a way to basically look at the pathology of those eyes and see whether the tumors were more advanced depending on demographic and socioeconomic risk factors as kind of a proxy for time to diagnosis of those tumors. And what we found is that race, ethnicity, and insurance status were all risk factors for more aggressive, more progressed disease in those patients' eyes compared to, just based on those factors. So suggesting that, it's likely that based on those factors that these patients were getting diagnosed later than their white non-Hispanic counterparts. And that was true when we looked at individual factors, and we looked at these factors kind of combined with each other. We've then gone on to look at disparities in bone tumors. So these are some of the most common solid tumor cancers in kids, especially in adolescents. So for this study, we use the Survival Epidemiology and End Results database, which is a national cancer registry that covers about 27% of the US population and is meant to kind of represent the geographic diversity of the country. So it covers a lot of cities, it covers some whole states, some rural areas, but again, meant to represent the overall diversity of the US population. And we looked at an 11-year time frame. And so in osteosarcoma, which is the most common bone cancer in kids, we found that Hispanic patients and those living in areas where they were more likely to, there were populations that were more language isolated. So mostly Spanish-speaking patients who had less English proficiency were more likely to present with metastatic disease. And then patients who had public insurance versus private insurance had increased odds of death from osteosarcoma. In Ewing sarcoma, we found that non-white adolescents, and as well as adolescents living in high areas of poverty, who had metastatic disease diagnosis, were more likely to die of disease. And so we came up with this model kind of based on this study, because we often think about, so when we talk about cancer disparities, is a lot of this because patients are presenting later and hence have more aggressive disease when they present. But a lot of studies have shown that if you just look purely at time to diagnosis, so the time from initial symptoms to the diagnosis of cancer, that doesn't necessarily seem to impact the stage at which patients present. So we came up with this model thinking that it was very important to think about time to diagnosis, so time from symptoms to first diagnosis of the tumor, and delay in diagnosis. So more really an understanding of barriers to care that patients faced, and kind of was their diagnosis made later than it should have been based on their symptoms. We need to think about these two concepts as distinct. And so in this figure here, this kind of represents this difference. So if we think of patient A, the blue patient here, as having a bone tumor that is kind of less aggressive and slower moving based on the lower slope of this triangle here. And then patient B and C, the green patient, as having a more aggressive cancer based on the higher slope here. If we just purely think about time to diagnosis, time to diagnosis, we hypothesize, is really based more on the biology of the tumor. So there may be biological risk factors that cause symptoms to develop more quickly and some that develop more slowly based on the kind of aggressiveness, the biological aggressiveness of the tumor. So if we just think about time to diagnosis, if we think about when patients are diagnosed, so when they first present for care, this white bar here, and then when they're diagnosed, this black bar here, the red bar is kind of when patients experience metastatic progression of their tumor. So if we just look at time to diagnosis, patient A, the blue patient, is diagnosed later because their tumor is less aggressive. Patient B is diagnosed sooner. But neither of them, presents with metastatic disease because they were both diagnosed in a timely way before their tumor became metastatic. So if we just look at time to diagnosis, that may be a reason why we conclude in those studies that timing doesn't matter to metastatic disease at diagnosis. What we really may need to look at more is delay in diagnosis. And so in this case, both patients A and C are diagnosed at the same time, but patient C had the more aggressive disease and experienced a delay in their diagnosis due to socioeconomic factors that then made their tumor present as metastatic. So again, if we then just look at time to diagnosis, we may again conclude that metastatic, these patients had the same time to diagnosis. Patient C presented with metastatic disease. So again, timing doesn't matter, but it really more need to understand the delays in diagnosis, these barriers to care that patients face. And that really takes not only just looking at time, but the experience that patients have had. So we've gone on to try to study this hypothesis in a Wilms tumor model. And so Wilms tumor is a kidney tumor that mostly occurs in kids. And what we found so far is that it may be more complex than we thought, because what we found is that it seems like there are multiple factors in terms of tumor biology and barriers to care that may impact the chance of metastatic disease and the timing of diagnosis. And so this is clearly an area that needs a lot more study, probably in larger populations and across other cancer subtypes. Okay. So one population that we've been interested in terms of childhood cancer disparities is patients who die within 1 month of their cancer diagnosis. Because we know that, we've made a lot of advances in childhood cancer treatments and outcomes, but when kids die soon after they're diagnosed, most of the time before they've even begun treatment for their cancer, those kids can't really benefit from all the advances that we've made in cancer. And we found in another SEER study that early death in childhood cancer had multiple risk factors, many of which were racial and ethnic and socioeconomic in nature. And so Black patients who had leukemia were more likely to experience early death, whereas Hispanic patients with both leukemias and CNS tumors were more likely to experience early death than their non-Hispanic counterparts. And then patients from disadvantaged areas in terms of income were also more likely to experience early death from leukemia compared to patients from areas with higher incomes. So we've gone on to look at early death in an individual basis. So now we've moved away from cancer registries and we looked at individual patients who experience early death here at Children's Hospital Colorado. And this is work that has been led by Katie Lind, who is started work on this as a pediatric resident and is now one of our pediatric hematology oncology fellows. And so what Katie found is surprisingly, when we looked at all of the diagnostic timing for our early death patients, that our early death patients here represented by cases actually had longer time from their first symptoms to diagnosis of their cancer than these control patients from a cohort of patients who did not experience early death. So lived at least 1 month from their cancer diagnosis, and most of whom are long-term survivors. And that was surprising because we know that the early death patients tend to present with often very aggressive, kind of highly progressed cancers. And so this, raised the possibility that there are barriers to care that our early death patients are facing, that, if we could address, could move them into the control group of patients who, hopefully become long-term survivors and are at least able to live long enough to benefit from the treatments advances that we've made. And so Katie is now looking at this population in a prospective way. So patients who experienced early death, we're now working on starting interviews of their families in the 3 to 6 month period after they've died to really understand on an individual level the barriers to care that these families faced, and seeing then if we can start to intervene in this population and move these patients into the long-term survivor group. So this is a feasibility study that we're working on first that we've opened here at Children's, and we're working on opening at several other large children's hospitals around the country. And the hope is then to move this to a larger study later. Okay, so now I'll talk a little bit about work we've done looking at brain tumors in kids and disparities in this disease, since I specialize in pediatric neuro-oncology, and so this is really my area of expertise. So again, we did a SEER study looking at patients around the country through SEER since 2000. And we were able to do census-based assessment of socioeconomic status, individual level racial and ethnic assessment, and then we had insurance status for those patients starting in 2007. And then we correlated those characteristics with both metastatic disease at diagnosis and then with overall survival as well. So we found that both Black patients and Hispanic patients, even when we controlled for other factors in terms of their disease and across our models, had very significantly increased risk for mortality from their brain tumors versus their white non-Hispanic counterparts. And then when we looked at purely extent of disease at diagnosis, so now we're really focusing on those kind of pre-diagnostic factors, right? The presentation of patients, their quality of primary care to get them kind of diagnosed in a timely way, so that they hopefully present with just localized disease. We found that Black patients did not seem to have a greater risk of metastatic disease at diagnosis compared to white patients, but Hispanic patients did have a higher risk of metastatic disease at diagnosis compared to non-Hispanic patients. And then we looked at a stratified analysis. So now we looked at separately at patients with localized disease at diagnosis and metastatic disease at diagnosis, again, to try to understand now the post-diagnosis factors, the quality of treatments that they were receiving once they were diagnosed. And here we found that both Black and Hispanic patients with both localized disease and metastatic disease had poorer survival outcomes, even when we controlled for their extent of disease at diagnosis, suggesting that there are post-diagnosis factors that are responsible for these disparities as well. So we've gone on to do, again, an individual level assessment of pediatric CNS tumor disparities based on our Children's Hospital Colorado cohort. And so this really allowed much more detail in our investigation of these patients. So from the SEER standpoint, we're really, again, only able to look at socioeconomic factors on the census tract levels, but we were able to look at those factors on an individual level in our individual patients at Children's. We were also able to look at individual treatment and the timing of their diagnosis. Again, not as much the barriers to care on an individual basis, but maybe some of that because we looked at kind of social work notes when patients were first diagnosed, and documentation of those social determinant risk factors. So we found that Black and other non-white patients were less likely to receive both cytotoxic chemo and to be enrolled on a clinical trial. But we did not find overall that Black or Hispanic patients had poorer survival outcomes than our white non-Hispanic patients. And we think that may have something to do with kind of the safety nets that we have here in Colorado of both Children's and Denver Health in terms of high quality primary care that hopefully gets all patients diagnosed in a pretty timely way. We did find that patients with social concerns were more likely to receive radiation, targeted chemotherapy, and any form of chemotherapy overall. And the significance of that is I think we're still thinking about that because the type of therapy that we recommend in pediatric CNS tumors depends a lot on the specific cancer subtype. But it also, sometimes depends on specific circumstances for patients too. And that's something we're continuing to investigate. we did find that Black patients and those who had social concerns, who had low-grade tumors, were diagnosed more slowly than their counterparts. And then, interestingly, Asian and Pacific Islander patients and children living in rural areas were the ones who had a worse overall survival. I've talked some before about, kind of tumor biology playing a role in disparities. And so we've been really interested in this question. And we have a large CNS tumor bank here at Children's because of the efforts of our neuro-oncologists and surgeons. And so we were able to look at gene expression in these tumors based on race and ethnicity, because we always get the question, kind of how much does biology play a role in racial and ethnic cancer disparities, right? Is it the case that maybe Black and Hispanic patients have more aggressive tumors than their white non-Hispanic counterparts, and that may play some role in disparities? Now, we would expect if that were the case, that there would also be cases in which Black and Hispanic patients, had less aggressive tumors and may have better outcomes. And that's generally not what we've seen when we've looked at outcomes. So it suggests that, kind of biology may be playing less of a role, but we wanted to try to investigate this. So far, what we found is that in terms of gene expression based on race and ethnicity, there are likely differences in the immune pathways, so that kind of the tumor microenvironments, but not tumor expression, at least so far from what we've seen. We haven't yet looked at DNA and specific mutations of these tumors, and I think that'll be important to look at as well. So we're still kind of working on, again, kind of looking at the biological factor roles. Okay, so then we've gone on to start some interventions in CNS tumor disparities. And so the first of these is a study in which we're doing qualitative interviews with families and patients who were newly diagnosed with pediatric brain tumors or have newly been diagnosed with a recurrent tumor. And we want to understand kind of how, when we talk about treatment options for these families and patients, how the families are thinking about kind of how those different treatment options may affect their children's quality of life, their and just kind of family factors like transportation, parental employment, and those kinds of things that we kind of are separate from the kind of specific side effects and kind of treatment outcome expectations of the tumors. And this really comes from the fact that we saw a lot of those kind of post-diagnosis risk factors and causes of disparities. So, is it that patients who have socioeconomic risk factors, kind of maybe thinking about treatment options differently, and that may affect the quality of treatment that they're getting? And then we do follow-up interviews several months after the initial interview to kind of see how the reality of the treatment matched up with what we discussed originally. And so this is ongoing, and the analysis is ongoing, but it should really give us some insight into why families choose the treatments they do, and whether there are kind of demographic and socioeconomic risk factors that may play into differences in quality of treatment and eventually into outcomes. And then the second intervention project we've done is taking a public health campaign from the UK called Head Smart, that was basically about symptoms of childhood CNS tumors and how to recognize them and get patients diagnosed as quickly as possible. This program in the UK had a measurable impact on the speed at which patients kind of nationwide got diagnosed there. And so we took this program and we created a educational program for primary care providers to kids in Colorado about the timely diagnosis of pediatric brain tumors. And then working with the Cancer Center and the Community Outreach and Engagement Office, we've been able to get this educational program out to between 400 and 500 pediatric providers and family practice providers around the state. And what we've done is we ask these people who are participating in the educational program to fill out a kind of a pre and post analysis of their understanding of the diagnosis and symptoms of pediatric brain tumors. And we found that, the program, at least in terms of their understanding, is having, a very significant impact. Now, I'll talk, I guess, a little bit more about future work on this in a moment, but just kind of summarizing, kind of the work in childhood cancer disparities. We've gone from, kind of identifying risk groups and the existence of disparities to, kind of looking on the more individual patient level to really try to determine causes of disparities. And then now, kind of designing and implementing some early interventions. And this is a kind of complicated flow sheet that we had in our review of pediatric cancer disparities, but really shows kind of the interplay of many different factors, from things like language barriers, socioeconomic factors, implicit bias, and cultural factors that all kind of impact access to care, insurance, adherence to cancer therapy, that then kind of all end up being causes of both racial and ethnic disparities and socioeconomic disparities in pediatric cancer. And then we have biological and genetic differences here as well. Again, something that likely plays a role. We certainly know it does from adult cancer, but are still investigating that. Okay. So then other ongoing work that we're doing and some next steps. So we've done a registry study. So the Children's Oncology Group, like I'm sure all of the pediatric CRAs on the call know, is part of the NCI, and it's basically a group that includes almost all of the children's hospitals in the country, who together run most of the large clinical trials of childhood cancer treatments in the US and Canada. And so from COG, we have kind of the largest registries of childhood cancer patients in the world. And so we've worked on studying disparities using those registry studies, and have recently submitted a paper using those registries to look at disparities in two common childhood cancers, Hodgkin lymphoma and soft tissue sarcomas, including rhabdomyosarcoma. We're still working on the analysis of germ cell tumors and retinoblastoma, but what we found in Hodgkin's was Black race and lack of insurance were correlated with increased extent of disease at diagnosis. And then in the rhabdomyosarcoma patients from bilingual households, from more red line census tracts, were more likely to present with metastatic disease at diagnosis. We're also doing a study of pediatric cancer understanding in healthy teenagers. So basically, we're interested in understanding if there are demographic and socioeconomic risk factors that may be correlated with decreased understanding of the symptoms and kind of myths and truths among around childhood cancer that may lead to some of these disparities based on presentation, right? So are there risk factors that lead kids to not present to medical care and subspecialty care in a timely way with their cancers? We want to understand, kind of where those things may start by surveying healthy teenagers about their understanding of childhood cancer. And then we're taking our early death project kind of from this pilot stage in which we're doing interviews of early death families. We're hoping to expand that to kind of both a combined retrospective and prospective study through which we would kind of develop a very broad understanding of the risk factors for pediatric cancer early death, so we can take that to interventional levels too, whether that be on a public level, public outreach and public health, to kind of maybe to the primary care level, right? Can we get primary care providers to recognize as early as possible patients who are coming in with cancer and are very sick and at risk for dying very soon? And then we're working on kind of adapting our Head Smart work to a project that we could take nationally here in the US to hopefully have those same impacts that they had in the UK in terms of timely diagnosis of pediatric brain tumors. And then, since I do work in the lab as well as epidemiologically, we're, again, really interested in the interplay between biological factors and demographic and socioeconomic factors. One thing that we haven't talked about yet is that when we look at lab models of cancers, both in adults and kids, the populations from which those models come and the populations from which we have, kind of our broad genetic data on cancers, minority, racial, and ethnic patients are very underrepresented in both the models and in the genetic databases. And that's something we need to understand to a greater level in the PEDS world especially, and then try to make those models and databases much more representative of the US population as a whole. Okay, so I think we can learn some about interventions that are being developed and have been developed in adult cancer to address disparities. So one of those has been engaging patient navigators. So these are professionals who act as liaisons between patients and the healthcare system to really help cancer patients navigate the healthcare system and help address those social determinants of health, such as by improving screening that may impact their outcomes. And then we know that it's very, very important to partner with community leaders and community institutions to help medical providers in the medical system disseminate knowledge through the community and build trust with patients that we may have lost from problems with the health system in the past. We also know that it's really important to diversify the healthcare workforce so that patients are seeing that their populations are represented in the populations of healthcare providers who are taking care of them, and also having providers from those communities be part of leadership and decision making in the way that studies are designed, in the way that cancer treatment is performed. And then there's also been study of use of what we think of as now pretty basic and inexpensive technologies like text messaging, telehealth, and then mobile screening outreach in order to can help with increasing screening in at-risk populations and increasing the effectiveness of treatment for cancer. And then finally, what I just talked about is the adults have done a better job, although not a sufficient job yet, of getting better representation of minority, race, and ethnic populations in biological models and genetic databases that are used for a lot of lab-based research in cancer. So there are differences in adult and pediatric cancers that impact kind of how we can use some of these interventions, but there's some commonalities as well. And so the difference is obviously that, there are different cancer types in kids, and then the incidence is very different as well, right? So because the incidence of childhood cancer is so much lower than in adults, we don't do a lot of childhood cancer screening because the incidence is low and the screening doesn't tend to be kind of cost effective or medically effective. And then, we see a lot lower impact of kind of lifestyle factors in pediatric cancers, which, could tend to develop at, again, kids very young age before they've been able to be exposed to a lot of those lifestyle factors. But there are commonalities as well. And so we certainly see the presence of disparities across cancers in both kids and adults. And we know that the causes are similar and multifactorial in both groups. And then many of the interventions, so like we talked about, kind of diversifying the healthcare workforce, using community liaisons and really partnering with community institutions can be effective, I think, both in adults and kids. And so this is a table from again, a review of lung cancer disparities that really identifies how the community can play a central role in kind of all of these interventions. So from kind of identifying concerns to designing interventions to studying those interventions in research, interpreting the findings from the studies, and then kind of really helping our increased public understanding of the results of the studies and the changes that need to be made in terms of cancer care. So just to summarize, really everywhere we've looked, both in adult and childhood cancer, we've found racial, ethnic, and socioeconomic disparities in presentation and outcomes. And the causes are somewhat different across cancer subtypes, but we know are multifactorial and involve both pre-diagnostic, so those quality of primary care, kind of cancer understanding and biological risk factors, and then post-diagnostic as well. So the quality of treatment, the quality of survivorship care, access to clinical trials and things like that. And interventions are still developing and certainly not adequate to this point. And some of what we need to do to intervene to address adult and childhood cancer disparities is system-wide. So, it's increasing insurance coverage overall. It is diversifying the healthcare workforce. But some of the interventions we need to make can really be tailored to specific groups and communities. And can be, kind of much smaller and on individual levels, and are just as important as kind of the system-wide changes that need to be made. All right. I would really like to thank many people, both across the Cancer Center, across Children's and our Department of Pediatrics, and then many really dedicated and talented trainees that I've worked with through this scope of work. And then I would like to acknowledge the Cancer Center as well, that has funded a lot of the work we've done, especially in CNS tumors, as well as the Morgan Adams Foundation and Alex's Lemonade Stand Foundation, who have funded other disparities projects that we have worked on. And thank you guys very much again for coming today, and I'm happy to take any questions. I can see the chat. So feel free to put them in the chat or just unmute and speak up.
Dr. Green, I had a question. So a lot of the interventions you mentioned involving early intervention, screening, high quality primary care. I'm curious if there are any interventions that your team has looked at or have been thinking about, really at that time of diagnosis, maybe when it's getting to a more dire situation, to assist families, really when it's go time.
Yeah, it's so I think the intervention, the kind of provider education in brain tumors that we've done is that's kind of the hope and purpose behind that, right? Is to that, because patients with pediatric brain tumors can often present quite sick, right? If those tumors grow to a large enough size or become disseminated. So kind of how the kind of point of that project is how we get patients in when they've come to kind of their primary provider for the first time. Now, like we see almost in all childhood cancers, because childhood cancers are rare, it's not the first thing that any doctors and other providers think of when they see kids, and a lot of the symptoms of childhood cancer are similar to other much more common childhood diseases. And so, if we did CT scans and extensive blood tests on every kid who came in with any symptom of cancer, we'd be doing that on way too many kids. And so it is normal to have, kind of more than one visit before kids get diagnosed with cancer, but we want those patients, kind of coming in when they're still relatively healthy, kind of on that, maybe that second visit when providers kind of see that pattern of symptoms, combination of symptoms that aren't kind of following the script of more common diseases, so that we can get those patients in faster. In terms of addressing, that actually like on the family level, that is something that I think, still needs more work. And I think, those are the projects that are going to be really, I think, challenging to do, right? Kind of like getting information out to, the public in general, obviously is a lot more challenging and expensive. And then I think we also run, the risks of, kind of creating panic, among families, right? Like if we have a campaign about childhood cancer symptoms, and then, that creates a lot more stress and anxiety and, kind of more visits for kind of common symptoms that, again, aren't related to cancer among the public, then I think we need to kind of think about, kind of the risks and benefits of those types of interventions. But I mean, clearly it's been done effectively through like the Head Smart campaign that I mentioned. So yeah, they're definitely things that we're thinking about, but are still pretty in the early stages, and we just have to be kind of thoughtful about the shape those would take.
Sure, thank you.